So I thank the Indian Psychiatric Society, Tamilnadu chapter, office bearers, headed by our Honorable President Dr. C. Panniselvan sir. I extend my thanks to the organizing committee of this Midterm CME for practitioners, headed by respected Dr. K. Ramakrishnan sir, for providing me this great opportunity to deliver a talk on a very controversial, important topic in day-to-day clinical practice, namely schizoaffective disorder. With the permission of the chairperson, Dr. Ravi Shankar sir and Nirmal sir, I am starting the presentation. Yeah. So, when Dr. Arun Kumar sir called me and he told that the organizing committee has decided to, he suggested a topic, namely schizoaffective disorder, how much we diagnose. So the topic itself, sir has created a question, how much we diagnose. So I was thinking in terms, I was thinking in my mind, he has created a question, how to answer this question. I tried to look into certain literatures. When I was trying to look into literatures, several other questions come into my mind. So I thought if I have to answer the question of the topic, how much we diagnose, I thought several other questions need to be answered before we have come to the conclusion. Okay. So the first question that come into my mind was, what is schizoaffective disorder? I tried to find certain literatures and had some answers about that. When I was reading about getting some answers about on this topic, next question that come into my mind is, who have schizoaffective disorder? So what is the epidemiology? What is the prevalence and gender specific? All those things. Next, after having those understanding, I had another question in my mind, which was when to diagnose schizoaffective disorder. So what the current nosology says, how to diagnose in the current nosological terms, like that. After coming to certain understanding of the current nosological status, then I find there were real difficulty claimed in many literature on diagnosis of schizoaffective disorder. So I was looking into literature, how difficult is to diagnose schizoaffective disorder. So after finding some information on that, then I was wondering, why should we diagnose schizoaffective disorder? So after getting answer for those things, so I was trying to complete my presentation by adding, were there any treatment guidelines for managing this particular schizoaffective disorder? Okay, so with this outline, I am going to present this particular topic. Okay, yeah. So the first question, what is schizoaffective disorder? By just seeing the term schizoaffective disorder, it will easily come into our mind. Schizophrenia and mood disorder together is called as schizoaffective disorder. When we compare this to a soup noodle, soup in one bowl and noodle in the other bowl, and together we call it as a soup noodles. When soup is more and noodle is very less, it can be called as soup. When noodle is more and soup is less, we can call it as a noodle. When both are equally there, then we can call it as a soup noodle. So, whether we should call it as a soup noodle, soup noodle, or soup and noodle in the different bowl, like that. So it will be interesting in the next few minutes to have a healthy discussion on this area. Okay. Though the term schizoaffective disorder, in the terminology itself was very clear, schizophrenia plus mood disorder is called schizoaffective disorder. But when we try to find from when this particular controversial things have happened, many of the literature was trying to code few historical persons. Whenever we try to see in about schizoaffective disorder, one of that is this person called Ludwig Kalbam. So in his writing, he has mentioned a term called Vesenia tipia circularis. Though manic depressive illness was seen as a separate entity, dementia precox was seen as a separate entity. But here he has found some person, after having several episodes of mania and depression, the person is going to a state called dementia state. So he is trying to bridge or trying to differentiate that there are some kind of illness which is not a plain mania and depressive illness. There are something more than that, and he named it as Vesenia tipia circularis. So next, our Emil Kraepelin, who has given famous dichotomous classification, he himself, after a few years, he doubted that by just dichotomous theory, and he himself noted there is a third polarity of manic depressive illness which can be called as mixed state. Okay. His, again, Emil Kraepelin's understanding was challenged by next come Zudwig. Okay. This, as sir was saying, after these years, Kasanin has famous 9 cases. He has mentioned the term itself called acute schizoaffective psychosis. Okay. He is a Russian-born, American-turned psychiatrist. He first introduced this term, schizoaffective psychosis. Okay. G. Valiant, in his paper, he has mentioned almost every schizophrenic patient with remission could be also diagnosed as having schizoaffective disorder. What he is saying, initially Vesenia circularis, he told, after several depression and mania, the person is going for demented state. Here, something different, it's opposite finding he is trying to say, every schizophrenic patient with remission is going to have a diagnosis of schizoaffective disorder. So, there were many doubt whether schizoaffective disease is a part of a schizophrenia or it is a part of affective disorder. Many historians were giving evidence towards both. Some are saying it is more of a schizophrenia, and few are saying it is more of mood disorder. So here, Jules Angst, a Swiss academician, he has raised this question: is mixed psychosis is an affective illness? So, though we at the outset, by just seeing the terminology schizoaffective disorder, schizophrenia, and mood disorder, in historical aspects, we could able to find there are different informations on understanding this particular schizoaffective disorder. So, now, this has been reflected in our past nosological status also. In DSM, what they have told, initially it was subtype of schizophrenia. It was termed as a subtype of schizophrenia. Then it has been thought as there are 2 types of schizoaffective disorder, having excited state and depressed state, which is almost going towards bipolarity. Then they revise their diagnosis and they say that schizoaffective disorder is a diagnosis of last resort, and then they try to put into psychotic disorder not otherwise specified, and DSM-4, currently in DSM-5, like that, they are trying to keep that terminology under schizophrenia and other affective disorder. So there were a lot of different types of understandings, different types of doubts were raised in the past history. They say almost there were 28 different definitions of schizoaffective disorder has been documented like that. ICD also, from in the ICD 8, they have mentioned it is a part of schizophrenic psychosis. In ICD 9, they have mentioned it as a subtype of schizophrenic disorder, but though they are saying it's a subtype of schizophrenic disorder, the characteristic features are similar to mood disorder like that. In ICD 10, it is classified under schizophrenia, schizotypal and delusional disorder. So these were the different terminologies. There were some information has not been correlated between DSM and ICD itself, and history also, there were different understandings on this area. So now, again, initially, though we were thinking schizoaffective disorder is just a schizophrenia and mood disorder, now several other questions come into our mind. Okay. So we try to answer one question. Now many questions have come into our mind that whether schizophrenia and mood disorder together is called schizoaffective disorder, or variant of schizophrenia and with just a mood symptom is called as schizoaffective disorder, or is a mood disorder with incomplete remission of psychotic symptoms, or it is a midpoint between schizophrenia and mood disorder, or both are means completely separate. So all these questions come into our mind after the search of literature. So now we will move to the next question. Who have schizoaffective disorder? Okay. So who have schizoaffective disorder? Here I am trying to cover the epidemiological aspects. Fine. So who have schizoaffective disorder? Almost there is a problem here. The diagnostic criteria itself is a doubt. There were more than 24 definitions has been given in different times, and diagnostic criteria is keep on changing. So it is very difficult for any epidemiologist to do a longitudinal epidemiological studies to compare the various prevalence. But to the available literature, with available information, we could able to see from different studies, it is found that the schizoaffective disorder prevalence is around 0.2 to 1.1%. Okay, so it is actually lesser than schizophrenia, but in the higher term, so schizophrenia we say 1 to 2% we used to say. Okay, in the higher prevalence of schizoaffective disorder is almost matching schizophrenia, but very well less than bipolar affective disorder. So prevalence wise, it is lesser than schizophrenia and bipolar disorder that we could able to see. And then most of the IP admissions, inpatient admission records are saying almost 1/3 of the patient having a diagnosis of schizoaffective disorder in the discharge summary like that. Regarding age of onset, again there are some controversies. So 1/3 of the person is having means diagnosed to have schizoaffective disorder within 25 years of age. And another 1/3 of person is diagnosed to have schizoaffective disorder from the age of 25 to 30 years. And another 1/3 of person is having diagnosis of schizoaffective disorder more than 35 years of age. So when we are trying to compare this with schizophrenia or bipolar disorder, the second one, 25 to 30 years of age, the age of onset is similar to schizophrenia. The third one, that is more than 35 years of age, the age of onset is similar to bipolar affective disorder. So again, there is a doubt. It is some features is related to schizophrenia and some features is related to bipolar disorder. This particular doubt will be there in wherever we try to understand schizoaffective disorder. And they find that in among the schizoaffective disorder, depressed type is more common in older patients and bipolar type is more common in younger patient. And some interesting information, age of father less than 20 years or more than 35 years at the birth of the child is a risk factor for not only schizoaffective disorder, it is also for schizophrenia. The schizoaffective disorder shares this feature as like schizophrenia, like that. So these are the some of the epidemiological information I could find. When come to gender, female have more schizoaffective disorder than male. Almost 66% women, and men is 33 like that. Okay. Genetic risk, yes. Family history of if the person is having schizoaffective disorder means there is a possibility that the first degree relative can have either schizophrenia or bipolar. So again, when we are trying to look into the genetic aspects, both, if the schizoaffective disorder is there some person is having a family history of schizophrenia and some person is having the family history of schizoaffective means bipolar disorder. If the person is having a affective disorder, first degree means if the person is having a schizoaffective disorder, then there is a more possibility of affective disorder more than schizoaffective disorder as a first degree relative, and schizophrenia more than schizoaffective disorder. So to put an end to the conclusion, we are trying to say both schizophrenia and bipolar disorder can be a family history of family history in a person with this schizoaffective disorder. So that is understanding. So we have discussed two areas. What is schizoaffective disorder? And number two is who have schizoaffective disorder. Now the third question arises in our mind is when to diagnose schizoaffective disorder. Already we find there were some different in nosological status in DSM and ICD. So now I am trying to give the information what is available in the current nosological terms, which is DSM-5, ICD-11. Though ICD-11 is a current nosology, we are most of us are practicing ICD-10 also. So I have included ICD-10 information also under this heading only. Okay. So when to diagnose schizoaffective disorder? So to understand the criteria of DSM-5 schizoaffective disorder, we must understand the criteria A of schizophrenia. Okay. பார்க்குறதுக்கு சிம்பிளாக இருக்கும், கரெக்டாக புரிஞ்சு வச்சிங்களேன். ரெண்டு இருக்கணும், அதில் ஒன்றுலேருந்து 3க்குள்ளே இருக்கணும், சரிங்களா? அது ஒரு மாதத்துக்கு இருக்கணும். ட்ரீட் ஆகிருந்துச்சுன்னு வச்சிங்களேன், ஏற்கனவே ட்ரீட்மெண்ட் பண்ணியிருந்தாங்கன்னா அந்த 1 மாதம் இருக்குன்னு அவசியம் கிடையாது, அப்படின்ற மாதிரி தான் அதோடைய அர்த்தம். ஸோ criteria A of schizophrenia, 2 or more of the following should be there. So delusion, hallucination, disorganized speech, disorganized behavior, negative symptoms. Fine. So importance of negative symptom they have left. So the first 3 they are giving more importance. Okay. So at least 1 should be there among the first 3. Totally 2. Okay. And the duration should be 1 month. Okay. If the duration is less, it should be successfully treated with medication. If all these things has been fulfilled, then criteria A of schizophrenia is fulfilled. Okay. It is that simple. Okay. Next. When you try to, this is a schizoaffective disorder DSM-5 criteria. Okay. So criteria A is uninterrupted period of illness during which there is a major mood episode. Okay, major mood episode, which is major depression with depressed mood or manic, concurrent with the criteria A of schizophrenia. So one part criteria A of schizophrenia just I have discussed. The other thing is they want mood disorder should be there. Mood disorder means it should be clearly mood disorder. Mild depressive episode is not included in this. Minimum moderate or severe depressive episode, if it is a depressive episode. Manic episode is directly included, or mixed episode can be directly included, like that. Okay, that is another part. And it should be an uninterrupted period of illness. They didn't mention the term continuous, but they are saying uninterrupted period of illness. Okay. Criteria B, they are saying among the 1 and 2, so delusion and hallucination must be there for minimum 2 or more weeks, when mood disorder should not be there. At least in the course of the illness, there should not be mood episode. In that period, delusion or hallucination should be there for 2 weeks, like that. In criteria C, in majority of the episodes, both this symptoms that meet the criteria for major episode are present for majority of the total duration of the active and residual portion of the illness. It is not like a portion of the period, a mood symptom is there, a portion of the period psychosis is there, then you cannot diagnose schizoaffective disorder. And the last is, the disturbance is not attributed to the effects of substance, example, a drug of abuse, medication, or another medical condition. So this is a criteria given in the DSM-5 by as it is. So I cannot change it. So I am just reading it out. At the last, I will try to sum up and give some clear picture about how we can diagnose. Okay. Next, in ICD-10, it is mentioned as, in schizoaffective disorder, schizophrenic symptom, mood symptom should be diagnosed simultaneously within few days. Okay. In the same episode, concurrently, like that. So both should be there, simultaneously should be there. If at all some difference, it can be just within few days only it is allowed, not more than that. And the term should not be applied to patients who exhibit schizophrenic symptom and affective symptom in different episodes. Different episode, it is not allowed. In the same episode should be there. Okay. Some patient can have recurrent schizoaffective episodes. That is possible. That can be schizoaffective mania or schizoaffective depression. That is possible. And again, others have one or two schizoaffective episode interspersed between typical episodes of mania depression. Like one episode of mania can be there, one episode of depression can be there, and then schizoaffective mania can be there, and then depression can be there, then schizoaffective depression can be there. It is allowed. Okay. In that period, during the period when schizoaffective episode where depression and schizophrenia together is there, then we can call that episode as schizoaffective disorder. Okay. In ICD-11, they are clearly trying to say it is an episodic disorder. In DSM, they are trying to say it is an uninterrupted illness. Here they are saying it is a clearly episodic disorder, but again they are having a specifier that continuous can be there, like that, in which the diagnostic requirement of schizophrenia and manic mixed or moderate or severe episode are met within the same episode of illness, either simultaneously or within few days of each other. And then prominent symptoms of schizophrenia are accompanied by typical symptoms of depressive episode. Okay, moderate or severe, mild is not allowed, or a manic episode or mixed episode. And psychomotor disturbances like catatonia may be present. Symptoms should be there for 1 month. The symptom is not manifested by another health condition. So I have given actually what is given in DSM-5, ICD-10 and ICD-11. To make it understandable, what they are trying to say is, just a psychotic symptom is not counted. Just a mood symptom is not counted. What they are trying to say is, schizophrenia should be there. Okay, mood symptom should be there. Undoubtedly, it should be. It should be out. Undoubtedly, it should be. You should have diagnosed it. That is very very important. For example, the criteria of schizophrenia, they are giving more importance to delusion, hallucination, disorganized behavior. They are not giving importance to negative symptoms or the other things. Okay. Again, in the mood disorder also, mania is fine. When you are diagnosing the depressed disorder, they are leaving the mild depressive episode. Moderate or severe only they are taking. So what they are trying to say means, undoubtedly they should have schizophrenic symptom, undoubtedly they should have mood symptom, and it should be present in the same period. Okay. And for this specified period of time. That is the understanding they are trying to say. But in clinical setting, sitting and trying to understand the duration is very difficult. For example, in our clinic, when we try to get the history for the patient, எவ்வளோ நாளமா இந்த மாதிரி பிரச்சனை இருக்கு, 2 வாரமா அப்படிதான் இருக்குதுங்கய்யா அப்படின்வாங்க. அதுக்கு முன்னாடி நல்லா இருந்தீங்களா, அது மைல்டாக கொஞ்சமாக இருந்துச்சு, அது என்ன இருந்துச்சுமா, அது சும்மா அப்பப்போ கோவம் வரும், அது எவ்வளோ நாளாக இருந்துச்சு, அது ஒரு 2 மாசமா இருந்துச்சுங்கய்யா. அப்புறம் வேறு ஏதாவது தொந்தரவு முன்னாடி அதுக்கு முன்னாடி நல்லா இருந்தீங்களா, அது தூக்கம் மட்டும் வராதிங்கய்யா, தூக்கம் எவ்வளோ நாள் வரலுங்க, அது 1 வருஷம் வராதிங்க. So this is the usual history we get in the clinical setting. But here, after getting all the information, they are saying 2 weeks, throughout the period, 2 வாரத்துக்கு மூட் சிம்டம் இருந்திருக்கு, மூட் சிம்டம் இல்லாமல் இருக்க சமயத்தில் கரெக்டாக அந்த சமயத்தில் டெலூஷனோ ஒரு ஹாலுசினேஷனோ இருந்திருக்கணும் அப்படின்னு சொல்கிறாங்க. இதெல்லாம் எந்த அளவுக்கு வந்து நம்மளால் வந்து ப்ராக்டிக்கலாக வந்து பின் பாயிண்ட் பண்ணி டயக்னோஸ் பண்ண முடியும் அப்படின்றது டிஃபிகல்ட். ஸோ தேர் மே பி under diagnosis, over diagnosis or misdiagnosis which cannot be prevented even after ICD-11 or DSM-5 வந்ததுக்கு அப்புறமும் the confusion has been multiplied, then they are trying to solve the conclusion. We can have some understanding, that is different. Okay, everybody is having an understanding about what is schizophrenia, what is mood disorder, and we have some understanding about some schizophrenia and mood disorder together is called schizoaffective disorder. When you are trying to solve the problem, when you are trying to give the clear criteria, there is a misunderstanding or misattribution they have given in ICD and DSM-5. Okay. So in DSM-5 they have given under schizophrenic spectrum and other psychotic disorder. In ICD-11 they are given under schizophrenia and other primary psychotic disorder. They are given a code of 295 here, 6821 here. The duration again DSM-5, we assume that it is 6 months. In schizophrenia, they are saying 6 months. In schizoaffective, they didn't give the clear understanding in any of the place what the required duration is. So in some places, it is assumed that a period of 6 months, minimum of 1 month of active illness. So together, prodrome, active illness, and then residual symptoms together, possibly they are expecting 6 months, but it is not clear. In ICD-11, they have clearly mentioned 1 month is required. In both the ICD-11 and DSM-5, to diagnose schizoaffective disorder, the socio-occupational dysfunction is not mandatory. Okay, negative symptoms they are not giving importance. So that they are very clear. Okay, and different subtypes in DSM-5 and ICD-11. Some understanding between DSM and ICD-11, though they try to solve few things, still unresolved things are there. Okay. So one example how a schizoaffective disorder develops like that. So initially the patient may have qualified for criteria schizophrenia, and then the patient may have mood symptom, and then again a mood episode. Mood symptom is different, mood episode different. Mood episode can come in between, and it can go as a wave. At one point the patient may be having both the schizophrenia and mood symptom together. At that point, the patient can be diagnosed with schizoaffective disorder. And this is one picture. The combination of many things can be here to diagnose schizoaffective disorder. Okay. So now the ICD-11 and DSM-5, they are looking for dimensional approach than categorical approach, we know. So dimensional approach is addressing more of cross-sectional clinical picture. Currently, the patient is whether having schizophrenia or mood symptom or schizoaffective like that. When we are going for a categorical approach, it is giving a specific diagnosis and it is helping to understand course and prognosis. So what they are saying is in DSM-5 and ICD-11, they are trying to club both this dimensional approach and categorical approach. But generally it is understood that ICD-11 and DSM-5, it's more of a dimensional approach. Now, this question is, I think, valid now. How difficult is to diagnose schizoaffective disorder? So initially we thought schizoaffective disorder is a very straightforward question. And then we find that some of the person is having schizoaffective disorder in epidemiological things. When we look into the nosology, current nosology or whatever in the past also, there were many controversial things going on in diagnosing schizoaffective disorder that we could able to see. Now, what is the difficulty we are facing in diagnosing schizoaffective disorder? Real difficulties. Number one, the diagnosis of schizoaffective disorder is less reliable and less stable comparing to schizophrenia and mood disorder. Though you diagnose, the reliability and stability is less. One. Interclinician reliability is again very poor and it is variable. The same person, one clinician can diagnose as schizophrenia, the other person will diagnose as schizoaffective. So interclinician reliability is doubt. And it is already meant, we usually say that when you are able to find a Snyder's first rank symptom, it is more of schizophrenia. Then again in literature, when research says that 30% of the person who is having the affective illness, bipolar, mania, depression, they can also have Snyder's first rank symptom. So just having a Snyder's first rank symptom may not qualify for schizoaffective disorder. Okay. And some of the studies say that studies which looked into information processing, okay, the deficits what the schizoaffective disorder patient is having. When they are trying to research, the information processing have some deficit, which is similar to schizophrenia. This particular deficit is related to schizophrenia. Then again, when they are trying to look into emotional regulation part, then again, that part is similar to bipolar. The same patient is having the deficit in emotional regulation also, and also in the information processing. So it is creating a doubt. Okay, it is different. Schizophrenia is different, bipolar is different, schizoaffective is different, like that. And then impairment in frontal lobe mediated cognitive function is similar to schizophrenia. And I will give opposite understanding in the next few slides also. Okay, SAD means schizoaffective disorder. So schizoaffective disorder, bipolar type, they think that it is an extreme version of bipolar affective disorder. The depressed type, they are saying it is an extreme version of schizophrenia. If you are saying it is an, if you are able to find a schizoaffective disorder with depression, they are saying that it is like a schizophrenia, it is an extreme version, like that. Mood incongruent psychosis, if you are able to find, that is one pointer towards schizoaffective disorder, okay, in the clinical picture. When the first presentation in the history is delusion, it is more of bipolar affective disorder. When the first presentation is hallucination, it is more of schizophrenia. Okay, some of the genes, they try to find whether there is a change in genes, but there are many overlapping genes between schizophrenia, schizoaffective disorder, and mood disorder. Okay, and then some genes related to glutamate signaling pathway also, they are found as a common genes. And CSF levels of noradrenaline, PGA, noradrenaline, it is similar to schizophrenia. And some of the 5-HT profiles also, it is similar with BPD. So some things are similar to schizophrenia and some things are similar to bipolar, like that. So here, this diagnosis will give an understanding about genetic aspects. Some gene is more towards mood disorder, the other genes is more towards schizophrenia. There are some common genes which is common to both, like that. EEG finding, they are saying that 12 out of 18 patient is having BPD-like finding and 6 out of 18 patients is having schizophrenia-like finding. In stimulus response latency, they used to look into the P300 value. They are trying to say the reaction time is equivalent to like schizophrenia. Then again, the opposite understanding I will give in the next few slides also. So how difficult is to diagnose schizophrenia, schizoaffective disorder? There are differential diagnoses can be discussed when you are diagnosing schizophrenia. It can be schizophrenia, BPAD, unipolar, post-psychotic depression, unspecified psychosis, brief psychotic disorder, schizophrenia-form disorder, substance-induced psychosis, dementia with psychosis, malingering, delusional disorder, heavy metal poisoning, medication-induced psychosis, carbon monoxide poisoning. All these differential has to be considered when you are diagnosing schizoaffective disorder. Some of the pointer can be a high level of premorbid functioning, identifiable precipitating factor, periodic presentation, rapid onset of symptoms can be a pointer towards schizoaffective disorder. Okay, some of the disorders of behavior like mannerism or stereotypes, it is uncommon in schizoaffective disorder. Substance use is very common in schizoaffective disorder, though these are vague indicators. Okay, why should we diagnose schizoaffective disorder? So these, there are different doubts and things are going. Then why should we diagnose schizoaffective disorder? Why means higher rates of remission is seen in schizoaffective disorder compared to schizophrenia, and there are some chromosomes it appears to be related to schizoaffective disorder which is not in schizophrenia or bipolar, so like 1q42 gene, and less severe cognitive impairment than schizophrenia. And there we saw frontal lobe impairment is similar to schizophrenia. Here impairment in temporal lobe mediated cognitive function, it is more, it means it is different than schizophrenia. In temporal lobe mediated cognitive function is less in schizoaffective disorder compared to schizophrenia. So there are some differences could be find out in the presentations. That is the thing. Okay, some hippocampal and parahippocampal abnormalities specific to schizoaffective disorder they could able to find. There they find latency is different. Here they are saying that amplitude of schizoaffective disorder is higher than schizophrenia. Okay, there is a different information. Negative symptom is less persistent and more hospitalization if you are diagnosing schizoaffective disorder, and many high suicidal behavior can be there, and patient may have better insight in patient if you are diagnosing schizoaffective disorder. This is very important. Okay, there is a huge market a global rise in market size of schizoaffective disorder. In 2022 itself, there is a US dollar of 7.3 billion, which is going to increase US dollar of 8.92 billion. Amount is going to be spent for schizoaffective disorder. They find that there is a huge market because diagnosis of both antipsychotic, antidepressant, mood stabilizer, anticonvulsant, everything can be, everything is used in this particular diagnosis than any other diagnosis. So it's a huge market involved in this particular diagnosis. Fine. Okay, so suicide, 5% patient have a risk of suicide and better prognosis also. So any treatment for schizoaffective disorder, last two, three slides. So this is the usual treatment workup we follow in our department. We'll, if time permits, I'll discuss later. So treatment means pharmacological, non-pharmacological, two things. So first is give an antipsychotic treatment, supplement with benzodiazepine, rapid injectable antipsychotic if required, ECT if required. Okay, first episode. In multiple episodes, again atypical antipsychotic, psychosocial interventions, and if the patient is having if not improved, then go for lithium. Okay. Second line, if the two atypical antipsychotic is not required, go for clozapine. Third line can be typical antipsychotic, and then psychosocial intervention, then general health maintenance. Then fourth line will be injectable antipsychotic, like that. Only FDA approved antipsychotic for schizoaffective disorder is paliperidone. Okay. So when you are giving antipsychotic, first paliperidone, then ziprasidone, aripiprazole, risperidone. Secondary options, olanzapine. Tertiary option, more of haloperidol than fluphenazine. When I prescribing antidepressant, fluoxetine, paroxetine, sertraline in order. Mood stabilizer, lithium, carbamazepine, valproate, then lamotrigine. Fine. Psychosocial interventions are possible. Course and outcome. So high recovery, 83% recovery. Deterioration is only 20%, and then the variable prominence of affective disorder 10%. Okay. When you are trying to compare with the other disorders, schizoaffective disorder is having a better prognosis than schizophrenia, but less prognosis than mood disorder. So these are some of the poor prognostic factors. I can take in questions these things. So take home message of this presentation is schizoaffective disorder is an enigmatic and much debated entity. Need more research and observation. It's a nosological nuisance, but a clinical reality. Although shares many common features with schizophrenia and mood disorder, there are few distinct features also. A rise in global market of schizoaffective disorder warrants special attention. Careful treatment choices will help a significant portion of person with schizoaffective disorder. So now the same question I am raising to the audience. How much do you diagnose schizoaffective disorder? That is a question asked to me after understanding, having all this thing in mind. So now you answer how much you diagnose schizoaffective disorder.